It's really a pleasure to be presenting to you today. So I'm going to share my slides. As you know, the topic of my presentation is about living guideline recommendations. So if at any point you have any questions or comments, I'm happy that we keep this an interactive presentation, so we could do this as we go. I think it's a little bit hard to see the chat box on my side. So if you want to use the microphone, that might be easier.
Elie, also I'm happy to stop you if you like, and I can read out any questions and comments.
Yeah, that would be helpful. Thank you.
Okay.
Okay, so again, the topic of the presentation is about living guideline recommendations. Briefly, I don't have any financial disclosure to report. I do have intellectual disclosure related to my work on living guidelines, different projects, and living systematic reviews. The objectives are first to understand how guideline development fits in the context of informing decision in general, to be familiar with definitions of living recommendations and living guidelines, and then most of the presentation was about the processes of I'm sorry. I think there's a microphone. So processes of planning, producing, reporting, and disseminating living recommendations. And then I'll cover at the end the issue of accessing living recommendations. So in terms of background, as you know, during the COVID-19 pandemic, we were faced first with lack of much evidence, and people have to struggle with a lot of uncertainty. And very rapidly, the evidence base grew during the pandemic, and people reacted to this by developing rapid systematic reviews, rapid guidelines in order to respond to the decision makers. And as soon as those rapid products were out, we felt that they're getting outdated so fast that they are becoming invalid. So we brought the tool of living recommendations and living guidelines, so tools that have been in the making, in development before the pandemic, and then we use them to deal with that situation of rapidly evolving evidence base. So we went from producing the rapid to producing the living, whether we're talking about systematic reviews or guidelines. However, we realized with the experience that the concept of living comes with many challenges that we did not face with traditional guidelines, including the ability to keep up with the evidence, the ability to reduce error with the fast pace, and many other challenges. And that's why there was a need to better define the processes of living practice guidelines. And this was kind of the background for a work we have recently conducted at the American University of Beirut to try to come up with a framework for living practice guidelines. So I'm going to kind of present the process of this research work to develop the framework that characterizes the different processes of developing what we call living practice guidelines. Briefly, the methods of our review included a number of steps. Step number one was really the background kind of work on different number of reviews. So first we did a scoping review of the literature on living recommendations, living guidelines. Second, we went to the handbooks of guideline development of more than 100 organizations that develop guidelines again, and we looked at their methods, looking specifically about or at how the processes they use for developing living guidelines. But we also looked at the topic of updating guidelines, because we felt that we could learn from updated guideline, given that, if you think about it, living guideline is a special type of updating guidelines. And then we took that knowledge we got from the literature and from the handbooks, And we took a number, about a dozen of living guidelines, and then we tried to analyze them to understand what is exactly happening in the way they are reporting, the processes of how they put the panel together, of how they prioritize the questions, of how they conducted their searches, etc. So this led to development of the first draft of the framework. So we're calling this the draft framework. And then we tried to revise it. And then step 3, which was the refinement, that's the main step. We engaged a panel of about 50 international experts in the field of mainly living guidelines, but also living systematic reviews, and a number of other stakeholders, including public representatives, editors of journals, publishers, etc. So the way we engaged them was first through an online survey, through which we developed a second draft of the framework, and then we had a series of online meetings where we discussed some of the pending issues that we could not resolve through the online survey, and then we came with the final draft. What I'm going to present today is that final draft. It will consist of a number of definitions and figures. One of the first products of that process was to think about the context or how guidelines, or living guidelines in particular, but guidelines in general, fit in the context of informing decisions. And I'll show you the figure that tries to illustrate this. So you'll see that we have this large box where stakeholder engagement is key, because this came up as a key issue during the discussion. So you'll see that stakeholder engagement is there throughout these slides. So let's focus on the figure. In the centers, you have informing decisions for people affected by a condition. And the reason we have this there is because one of the challenges we and others have faced during the pandemic, where some of the work that was being done, for example, think about trials on a specific topic, people were conducting their trials, publishing them, and then as soon as their trials are published, they would declare victory. You know, they achieve their goal of publishing their trial. From the standpoint of systematic reviewers, from the standpoint of recommendation developer, that was not enough, because you needed individual participant data. You needed them to give you the basic data. You needed them to give you the data in a very timely manner, because in some examples, and you might have experienced this, someone would put out a news release about the findings of their awesome trial. We found that this new medication is a breakthrough. It reduces mortality by 90%. And then you have to wait 5 or 6 months to actually get the data in the published format, not even talking about individual participant data. So the concept was that the goal should always be informing decisions for people affected by a condition. Another way to say this, as a trialist or a systematic reviewer or a recommendation developer, you cannot declare victory until what you do, let's say trial development, is actually informing decision making and not just getting your work published. So this is really at the center of everything. And then you will see that there are multiple smaller loops. So we compare this to a flower with petals. So the petals are the different questions that come up around a certain topic. And if you focus on question A, you will see that there's a knowledge gap at the beginning. There's always the gap that comes up. And this is to illustrate another point, is that whatever work we do, they should address priorities as opposed to addressing questions that we come up with because we are interested in, or because of some other interest. So it always starts with a knowledge gap, and then it goes through the steps we are familiar with, which are evidence generation, which is the trials mostly, or the research, evidence synthesis to synthesize that data, and then recommendation development. And you can see that there are feedback loops. So feedback loops between recommendation development and evidence synthesis. These are very obvious because there is a need for back and forth, but also between evidence synthesis and evidence generators. So these are the trialists, the primary researchers, and also between recommendation developers and those who generate the evidence. And then you would hope that through going through this loops, you start with a knowledge gap, and then you end up with disseminating knowledge dissemination that would go back to informing decisions. So the framework, now to get more into the details of the framework of living recommendations. So we have come up with a set of definitions, but also definitions of the different processes. So I'll get to the definitions, but let me tell you, one of the revelations that we had is that we first started with trying to come up with everything in one diagram, but realized there are different aspects of guideline development for specifically living guideline development. So there's the planning phase, then there's the production. So this is the work of people who are doing the work. And then there is the reporting. So what do you include in your report? And that's separate from publishing. So publishing now is included under dissemination. We use dissemination to be more inclusive. But we realize that it is really important to define what's the difference between reporting and publishing. And that is something that we'll get to. And then another issue that came up is accessibility. How can people access different versions of the living guidelines? As you will see, a major theme is versions. How do we produce different versions? How do we disseminate them? But most importantly, from the other side, how can we facilitate the accessibility by the users? So let's start with the definition. So this is the definition. It's a refined definition of the one that we had published a few years earlier about living recommendation. It says a living recommendation is one that is kept current by an optimized guideline updating process that accounts for potentially consequential evidence as soon or shortly after it becomes available. So some of these or parts of this definition or proposed definition might be obvious, but a couple of things to highlight. The first one is the potentially consequential evidence. What has become obvious is that not all evidence is consequential, because sometimes you are at a level where the evidence is let's say moderate certainty evidence, and you have a small study that is high risk of bias, and you wouldn't say that this is potentially consequential. Or you might have a large study that is well done, low risk of bias, but where the results are totally consistent with the synthesized evidence that you already have. So that might not also be potentially consequential. A different example on the other extreme is when your current evidence is, let's say, low certainty evidence, and then comes out two large, well done, low risk of bias studies. So this is what would be considered potentially consequential. And the reason why this is important is because that could affect the process, could affect whether you move forward with certain processes, given the burden, given how much resources you need to develop living recommendation. The other part that I would like to highlight is that we say as soon as or shortly after it becomes available. The previous definitions were used the term as soon as, being too aspirational, too idealistic, but everyone has realized that as soon as is probably not doable, not feasible. So now people are referring to shortly after it becomes available. So some kind of reality check into the previous definitions. So now this is the definition of living recommendation. Some people would want to know what is the definition of a living guideline. The definition of a living guideline is simply, we define it in a simple way where we say a guideline that includes one or more related recommendations that are, and then you go on to loop back to the definition of living recommendation. So to avoid having different set of definitions and concepts, it's really a set of living recommendations that form a living guideline. Having said that, we realize that a living guideline might include living recommendation, but might also include non-living recommendation. So as long as it includes one or more living recommendation, it could qualify as a living guideline. So now one other aspect of a definitional aspect is that in a living guideline, the unit of update is the individual recommendation and not necessarily the whole guideline. So imagine that you have a guideline formed by 10 living recommendations. It is conceivable that for one recommendation, you have evidence coming out that is potentially consequential evidence where the panel has to meet an update because, think about when we are waiting for the vaccines and the first trial for vaccine comes out, this is the time for the guideline panels to update the recommendations. You cannot wait so you have data for all the other recommendations to update your guideline. You have to update that recommendation. Similarly, when you update that recommendation, there's no urge to update the other recommendations. And the reason we say, it might sound obvious, but in the previous approach of updating, what we used to do is when we make a decision to update a guideline, it's about updating all the recommendations in the guideline. So the unit of update was really the guideline. So now with living guideline, it is the individual recommendation. One variable or one definition that we have introduced, it was mostly about labeling something that was actually happening, is the living mode parameters. So we define those as the methodological aspects that characterize the living process, including frequencies of conduct of specific steps and any triggers for conducting those steps. So imagine that a living guideline or living recommendation is like a machine that is going at a certain pace. And the question is, what determines the pace of that machine? This is what we're calling the living mode parameters. So it could be about the frequency of updating your search. So you could say, I'm going to update my search every month. You could say every 3 months, every 6 months, and there is a range. And when you look at living systematic review, there's a wide range of the frequency that people have determined. So that's called the frequency of the update of the search, but you have other frequencies. For example, frequency of the update of the analysis, etc. But then there are also, for most cases, there are triggers. So even if you say I'm going to update my search every 3 months, it might be that if a new consequential or a trial with consequential evidence is published within that 3 months time frame. So before your next date of updating, that's a trigger that would force you to update your search and update your or move your process forward. So that's considered part of the living mode parameters. And then revisiting a recommendation is about reconvening the guideline panel to discuss the impact of potentially consequential change in the body of evidence. And here, body of evidence, it could be either the health effects or the contextual factors on the recommendation statement. So we refer to both health effects or contextual factors because it might be about the effectiveness of an intervention, or it might be, let's say vaccine, we have data about vaccine that is effective, or let's say suddenly, one day, Pfizer and the other companies come out and say, what, we're going to donate all the vaccines for free. So this is a contextual factor about the resources and the cost. And you could imagine that if you initially had some restrictions on the vaccine, you say, I'm going to give it just for the elderly, and then I decide, how to go down in terms of the age scale. Now you might change the recommendation, and as long as the vaccine is available, you could give it to everyone. So that's why the focus on both the health effects and the contextual factors. And the reason why we defined revisiting a recommendation is because there's a distinction between going back and revisiting a recommendation and between modifying a recommendation. Because you could revisit a recommendation, which is again reconvening the panel, reviewing the evidence. There might be some new body of evidence, but at the end they might decide not to modify the recommendation. So in this case, you have revisited the recommendation and the outcome is not modifying the recommendation. There was a confusion about the use of words because in some people's mind, revisiting a recommendation means that you would change the recommendation. So it's more about the process as opposed to the outcome. The process is about revisiting, the outcome is about modifying or not modifying a recommendation. So now I'm going to move to explain the different processes in the planning, production, reporting and dissemination, and accessibility. And I'm just checking, I don't see any comments or any question. Okay, so I'll go ahead and proceed. Okay, so one major issue in terms of developing guidelines is really about the planning. And this first figure is trying to illustrate this. And we figured that there are two levels of planning the process of living guideline. At one level, the organization has to decide to adopt the living guideline methodology because it's a major decision. And the other one is about a specific living guideline. Once an organization has adopted the living guideline methodology, then you talk about planning for a specific topic for guideline development. So let's start with the first one. So the first one is really about adoption. I have one example in mind where we were working with a clinical society in the US on guidelines, and for a while we've been incentivizing them, encouraging them to start a guideline process, and that's before the pandemic because it was nice, it's a nice concept, etc. But then they were very concerned, and for almost 2 years they didn't make any decision to move forward with that. And then came the pandemic, and this is when they decided, this is the time. So there's sometimes this trigger for considering the living mode, which in this case was the pandemic. I can tell you that with another organization that had not adapted the living guideline, they are just starting it now. The reason for this is because they issue recommendations about a class of medications, and there are reports coming out about the safety of those medications. So they want to keep their recommendations up to date, especially because it's a safety issue so they have adopted this living guideline. So these are two examples of triggers. Once you have the trigger, you move to the next step to assess the readiness of the organization. So assessing the readiness is really understanding what we're talking about today, the processes, what is involved in terms of human resources, in terms of financial resources, in terms of having the policies in place. So this is about assessing readiness. Once you assess readiness, you start working on the structure and the processes, which might include having certain committees, because the standard committees might not be quote unquote live enough. For example, the quality control, the approval of the guidelines have to be a bit more efficient. So these are the structure, but also the processes. So your handbook, the guideline organization handbook, has to be updated to reflect those processes. And you see there's some kind of feedback loop, because sometimes people start working on the structures and then they realize, what, maybe this is too much, I'm not ready. If they are ready, they establish the structures and processes. The next step is to prioritize what are the topics for which they need to develop living guidelines. And the reason for this is obvious, because they can't develop living guidelines for all kinds of topics because it's very time consuming. For those of you who have worked on living guidelines of living recommendations or living systematic reviews, it would be clear why this is very demanding. So they need to prioritize the topics, and there are different criteria that we've published a few years ago. One of them is that the topic is of relevance to decision making. Someone needs the data to make decision. It's not just because out of academic interest. That's one. A second condition is that there is uncertainty, current uncertainty. Because let's say there's a new topic for which people now decide to need to make decisions about, but the systematic review identifies high certainty evidence. You don't need the living guidelines, because you have the high certainty evidence anyway, and it's unlikely to change. And the third one is that if you have interest, if you have uncertainty evidence, you have to have at least something in the pipeline. That trials will be coming out, because if there's nothing in the pipeline and you know this for a fact, then there's no use of using the living process. So that's again the organization level, meaning adopting the methodology. Once an organization has adopted the methodology, decided on a topic to cover, this is where you go to the second row, which is about launching a specific living guideline. And here is the planning around that. So first, you have to develop a protocol, including the living parameters we have discussed. You have to assess the capacity for I think that there might be some microphones that are open. So assess the capacity for and sustainability for the project. And sustainability came up as an important element of the assessment for a specific project, to have the funding for that project, because otherwise, and we're facing this with at least one organization, you get to a point and say, my funding expires in 2 months. Do I have the funding to continue doing this, given that it might be resource intensive? Once you decide that, yes, I have the capacity, it is sustainable, you have to form the living working group. So the living working group are the typical group that are engaged in guidelines, meaning systematic review groups, the panelists, the other stakeholders that might inform different steps, the quality assurance group, depending on the organization. And, we call them living. Obviously, they need to be living, but it's about, being there, being available. So if you have a living systematic review group, they have to have the process of the living. If you have a living panel, you call on them on a very short notice. We have new evidence, we need to convene, etc. And then for that project, what you do also is prioritize PICO questions as part of, making sure that it's a feasible project and it's addressing the questions being asked by the end users. So that was the planning part. And once you have this in place, you can move to what we call the production part. And this is how we are figuring the production process for a living practice recommendation. So this might be a bit busy, so let me walk you through this one by one. So this is about a single recommendation. So this is not about the living guideline. And as we said, the unit of update is the recommendation. So you could imagine having this kind of process for each recommendation within the guideline, but happening at different time points. So the overall shape is the shape of a coil. Most of the previous conceptions of living processes are in circular. So we thought this way we are able to have the time factor being clear, going from left to right. You could see that there's a progression of time, but also you could illustrate what's happening with different versions. So the first loop is, you see at the bottom, recommendation version 1. The second loop, recommendation version 2, and then after many loops you get to recommendation version N. I just need 1 second. I'm being called from the clinic. Sorry for that. So So you see that there are different versions for the recommendation. So version 1, 2, 3. And then let's look at the top part. You have in green the initiation of the living mode. This is the first time you issue the recommendation. And then you have the maintenance, where you could go through a number of loops, 2, 3, 4, whatever it takes. And then at some point you get to the retire from the living mode, and we'll come back to this. But let's go back to the initiation and see what's involved in each of those loops. So in each of those loops, you will see that these are kind of repeated. The prioritized PICO question, that's one PICO question again. So you start with what is the prioritized PICO question, and based on that, you set your living parameters. Knowing, for example, depending on how how frequent the evidence is coming out, etc., so you could set different living parameters for different questions. Once you set this, you start going through the process of the surveillance, which in some cases might be 1 month, 2 or 3, based on your parameters. Some people do the, even if you do the continual surveillance, the alerts, at some point you need to say, okay, let me have a look at these alerts. And the question is how frequently. Once you go through the surveillance, you identify the study, you have to assess the body of evidence. Meaning synthesizing the evidence, etc. And then you move to drafting the recommendation. So kind of the basic steps of any guideline development, whether guideline, living guideline or not. So you draft the recommendation, and then you go to the dissemination. And dissemination is, we started with talking about publication. We end up with dissemination because it's a more inclusive term, especially because with living guideline, you disseminate through ways other than publication, through email, through social media, and other ways. And just kindly ask whoever has their microphone on, if you could please mute. So, and then you have the uptake and impact evaluation, which is what should ideally happen and then feed into the process. And in this case, you might need to revisit your PICO question because maybe the intervention you are interested in or the comparator is not being used anymore. Maybe because the population you are interested in is slightly different, because you have a different variant. Now you have to change what you're talking about. And then you will see that you go through those different loops. You might need to revisit your living mode parameter, either because of evidence-related reasons, or it could be simply because of pragmatic reasons. Again, you go through the loops, and at some point under retirement, you might or might not visit the PICO question, but then you make some assessment. Again, if you're not remember the 3 conditions for living recommendation. If you're not meeting at least one of them, this is typically an indication that you don't need the living mode. If it's not of interest to decision making anymore, maybe lockdown is not of interest to decision makers anymore, so you don't need to keep doing the living guideline. 2, if there is no uncertainty anymore, we have enough data, question of steroids in COVID-19, now we have high certainty data, we don't need to keep searching for the question of steroids in sick patients. Or 3rd, if we know that there's no trials anymore in the pipeline. So this is the retirement. So in parallel to this whole coil direction, you will see that the living evidence synthesis, I'm not sure whether this is obvious, there's this light blue arrow in the middle. It's showing how in parallel and embedded in this whole process of production of living guideline, you have the process of living evidence synthesis. Same with dissemination, it's a continuous process. So people who work as part of disseminating in terms of publishing in journals, publishing on a platform, or the social media, or sending emails, or the website of the organization, this is a continuous process. Another continuous process as part of this, you will see it now in the yellow arrow, are other aspects that are really important to keep living. So conflict of interest management. So people getting new interest that they need to declare, and then you need to manage. So that has to be living. Quality control has to be living. Stakeholder engagement. And one of the issues we've seen is what we are calling the living fatigue. People are just getting, tired of, being on repetitive calls and revisiting, data and then coming up with recommendations. So you need to have a continual stakeholder engagement. Same with sustainability. So you might have judged that this is sustainable, but with time you have to revisit to have enough funds. Are we getting more funding? And then crediting contribution. And this is referring to typically authorship. So you have people coming in and out of the project, whether on the living review or on the panel. So how do you credit those that contributed to previous versions and later versions? So that has to be a continual process. So now this is the production process. What I'm going to focus on next, if you look at this dashed kind of box on the right-hand side, I hope it's showing, it says figure 3 here. So I'm going to hone in on this part to reflect with you more about what's involved in the process. So we call this the 3 possible scenarios of maintenance phase of the living practice recommendation. And this is probably more relevant to living systematic reviews. So remember, this is part of the loop. So you do the surveillance, and there are a couple of decision points. So the first question, we said you'll update your search every month or 2 months. And then you do that. And then the main question you ask, is there new evidence? If there's no new evidence, then you're done. There's no new trials answering your question. You're done. Part of this would still be dissemination, because from the perspective of the user, it is important to know that although this recommendation was issued 6 months ago, on a monthly basis, this has been checked in terms of evidence, and then there's no new evidence. So practically, it is current. Although it was developed 6 months ago, it's still current because we have checked the evidence up to, the most recent date. So that's important. So this is where we introduce the concept of a timestamp. I come back to this. What you do with every surveillance, again, even if there's no new evidence, you update your timestamp in terms of the recommendation. So now, if the answer is yes, there's new evidence, the next question, is this evidence potentially consequential if there's a change in the evidence? And there are different ways of doing this. And different guidelines, organizations do it in different ways. So in some cases, it's just the chairs. So the systematic review team would send the data or the change in the effect estimates to the chair or the chairs of the panel. They would review them, and then they would make their assessment. If they feel that there's a potentially consequential change, they would move it to the next step, which was reconvening the panel. And in this case, this scenario 2, if they judge that it's not potentially consequential, they would stop here. There's an acknowledgement that there's new evidence, but this is labeled as not potentially consequential. And this is, again, disseminated. And the guideline, if, for example, you might go to the guideline website, they would say the date of the last search is, what you have under scenario 2, and then we've identified those 2 new studies judged as not potentially consequential. And, they might use, obviously, different terms. Now, the judgment about whether it's potentially consequential could be, kind of a rough judgment, or there could have been criteria. So is the evidence looking at, is there a new outcome that has not been assessed in previous studies or not? Has the certainty of evidence increased? Has the effect estimate changed? So some criteria that would make it potentially consequential or not. And it says potentially because really the decision on whether it's consequential is up to the panel when they meet. So at this point, it's potentially consequential. So you could imagine now that scenario 3 is where you answer yes, to the second decision point. And in this case, what happens is that you have to revisit the recommendation, or the panel has to revisit the recommendation. Again, just to emphasize, revisiting is about the process. It's about going back, discussing, and deciding on the recommendation. And it could lead to a modification of the recommendation or no modification of the recommendation. It could be either one. So the revisiting is about the process, and the outcome, modification or not, is a different issue. But with each one of these, every time you go through this loop, as someone who's in charge of or involved in this process, you could or you should update your timestamp, because you've done the work and it is up to date, even if you did not find new evidence, even if it's not potentially consequential, and even if you did not change the recommendation, you have a new timestamp. So now, another focus I'm gonna make is on this part, dissemination. So that's in the next figure. And remember, this is for a single recommendation. And here, this is where we get into the distinction between reporting and publishing / dissemination. So let's go together through this figure. On the left-hand side, we have what we call the reporting elements. And the way we think about the distinction between reporting and publishing is that reporting is what you, as someone who's drafting or writing the document about the recommendation, what are you including in that document? And publishing is more about how it's presenting, on which platform, in which venue, in what form, the linkages between the venues. And we'll come back to this, but just trying to make the distinction. So again, reporting elements is what you, as someone drafting the document, what you include. And what is specific to the reporting guidelines or reporting elements for living reviews. And just as a step back, all what I have presented today is really about what is specific to living reviews, or what is particularly relevant for guidelines. And all the other principles that we use for developing guidelines still hold. And we typically, what we use is the Jen McMaster checklist for a guideline development. So all of these 18 steps or domains still hold. And here we're focusing on what's specific for living guidelines. In this case, for reporting, you would report everything about the guideline in terms of the composition of your panel, in terms of your process of the systematic review. What we are highlighting here, what is specific to the living part. So one of the elements is the evidence surveillance timestamp that I had mentioned in the previous figure. You always need to keep that in mind. You need to mention what this timestamp is. And then the other part is the outcome of reassessment of the body of evidence that you have to report, meaning that we identified no new data, we identified one new study, we identified 3 new trials, etc., and the outcome of the recommendation visit, whether you modified the recommendation or not. And then you could take different combinations of these elements and a different level of details into different dissemination formats, into different venues. So let me explain what I mean by this. So venue 1 might simply be a press release where you say, we updated our recommendation, this is the new recommendation, because you want to get the information out. And you don't mention too many other details, so it's very superficial. So this is, let's say, the website. Venue 2 might be the guideline platform where you might have more space and more time to include more details, where you would include the timestamp, you would include the reassessment of the body of evidence, and then you issue the recommendation. Venue, what we have here under venue N might be the peer-reviewed publication. And here you might go into more detail about the reassessment of the body of evidence, include your evidence tables, and include the evidence to decision table, for example. So you have different combinations, again, with different level of detail. And this is where it gets into dissemination now, different venues. And those could be concurrent dissemination, or non-concurrent. And we've seen example where, one venue is quicker than the other. So you could do that. And part of this dissemination is also raising awareness. So that was the part about dissemination. Now, one of the issues is, how do you draft a living recommendation? So typically, the part that is the top part is the typical recommendation. The population X, intervention Y is recommended over intervention Z. And then you state strong condition recommendation, moderate certainty evidence. So here now what we recommend that in addition to this, you need some other information to report. So the evidence surveillance current to, so this is the timestamp. So you can tell that this is really critical with living guideline. You need to mention the timestamp. You could also mention the outcome of the recommendation revisit. Although you say, or when you say November 7, I would like to know that has this been modified from the previous version or not? So you could mention whether it's modified or unmodified from the previous version. The other thing to mention is whether this version is the latest. The reason for this is that the way those, and I'll go back very briefly to this, the way the recommendation are published in different venues is that you might have different publications, journal publication for the same living recommendation, but for different versions. And then you might land on the first version that is not the latest one, or even the second or third. As long as it's not the latest, that's a problem. And that's what we call the landing, the landing page, or where you land. And this is why with each one of those versions, because they are out there, whether on the website or in a journal publication or some platform, you need to indicate whether each version is the latest version. And that timestamp of this being the latest version, that needs to be somehow moved from one version to the next. So the technology might or might not be there, but this is ideal. You need a stamp, not just for the time. You need because the timestamp is specific for each version, but there's one stamp for each recommendation that should be applied to the latest version. And then you should, if it's not the latest version, there has to be some way to link to the latest version. So you could have the previous version sitting there and you say, this is not the latest version, click here to go to the latest version. Now, this is the last figure, and this is about versioning and accessibility of a living practice guideline. So up till now, we've been discussing one recommendation at a time in terms of production, reporting, and then dissemination. So in terms of accessibility, you have to think that now you have, like in this case, 6 recommendations included in living guideline. And because the unit of updating is not the guideline, it is the recommendation, they are not being updated at the same time. So for example, here the green is initiation, this is being updated, this is being retired at this point. While this, if you look at recommendation B, while recommendation A is being retired, B is being updated. And where recommendation B is being updated, recommendation D is being introduced. So there's lots of things happening at the same time and not, kind of in a perfectly concomitant way. And in terms of accessibility, you could think about it from 2 views. So if you start with the recommendation view, this is when you are interested in recommendation B, and you want to see the different versions of the recommendation. You want to know what has been, how this recommendation has evolved over time, what has the change or the changes been over time, and this is the recommendation view. And many people are interested in this to know the evolution over time. But most users are interested actually in this below, what we call the guideline view, which is the vertical one. Because if I'm interested in a certain topic, at any point, I want in one place to understand what are the latest recommendations on that topic. Recommendations A over G, I don't care how they evolved over time. I would like to know the latest versions of those recommendations. And this is the guideline view. The current challenge with guideline publication and in terms of accessibility is that both of these versions are not easily achievable because, and we know of examples of good living guidelines where each recommendation is published in a separate paper because they're not being updated at the same time. It's just the nature of the process, and it's because of the challenge of the technology. The technology might not be there. So at any point, if you want to know what is the latest version of each of those recommendations, you might have to chase different papers, and there's a risk that for a specific recommendation, you might not land on the latest version. And even with the recommendation view, the linkage is not that good that you are able to identify the different versions. Obviously, you could go to the references and check, but it's not as easy as it could be. So, so to end some discussion points. I guess so. Framework can help. This framework can help guideline developers in both planning and conducting their living guideline projects, or at least we hope that this will help them, and we hope that it will help them decide on whether to go for this kind of methodology or not. But it also can be studied to can help in studying the methods of conducting reporting and disseminating. And actually, the reason why we came up with this framework is because we are developing a project to study the methods of living guideline. We're so confused of what are we exactly studying. So this is why we decided to go with this framework or develop it. I already mentioned that this builds on the Jen McMaster guideline development checklist, and what we present here is mainly the points specific to living guidelines. And the last point is to acknowledge that there's definitely more research needed to address the details. So this is a high-level view of these processes. There are lots and lots of details that need more work. So this is an acknowledgement of the team who worked on this. And thank you, and thank you for your attention. Yes, we can open it for questions or comments.
Thank you very much, Dr. Elie. Are there any questions? If you have any questions, you can unmute. I see there's a hand by Tamara. Tamara, you can go for it.
Thanks. Hi, Elie, and great to hear the talk and have this overall picture. Really interesting, and it's quite a lot to take in, because all, moving from the concept of an overall guideline to the individual recommendations and updating them, but it makes a lot of sense. I guess my question was around, for those of us working here, we're often needing to adapt from other guidelines in various ways that we do it. And I'm trying to understand the interface between the living guideline and adaptation of a guideline. In a way, it makes me think like maybe there's a greater chance of having an up-to-date guideline than you usually find when we're trying to adapt. But I don't know if you've had any thoughts on that, on how they interface. Yeah.
Yeah, thanks, Tamara, and thank you for contributing to the development of this framework. So it's a tough question, and this is a question that is coming up, I guess, with now with the living guidelines. So, coming from a middle-income country, soon to be a low-income country, we prefer to adapt guidelines and recommendations as opposed to develop new recommendations for the obvious reasons. And although it's supposedly a much easier and briefer process, it still takes us for adapting guidelines 3 to 6 months. And now we have this other process where the recommendations keep coming out with the living process. So we kind of need an adaptation, a living adaptation process of these living guidelines. And I don't think there's much experience in this. We're still, we're struggling with adaptation, we're struggling with living guidelines. So doing living adaptation of guidelines will definitely be a struggle. I guess one way, there are different potential solutions for this, but I would also be interested in hearing your and others' thought on this. It would be good to have what we've been advocating for a while, a kind of collaborative approach to dealing with evidence, not just evidence synthesis, but also guideline development, in the sense that to start with evidence synthesis, and this has been very flagrant during the pandemic, for the same systematic review or question, I should say, for the same question, there are, tons of systematic reviews being done at the same time. So imagine all the screening, all the searching, all the data abstraction that is just being duplicated and duplicated. And we haven't found a way as an evidence synthesis community to come together and have a collaborative process where it would be good to do some replication, so some verification, but the priority should be really for avoiding this, duplication of efforts. But the same thing could apply to guideline development. So instead of a central organization developing the guideline and then being handed to us to adapt it, that has to be a more open process, because the evidence about the health effects is the same. So if someone is, preparing those, that has to be shared with everyone at different levels, high income, low income country, national, or maybe sub-national organization. And then what you would have to do at the local level is gather the contextual evidence, and then maybe have a parallel process as opposed to, like a two-step process.
Yeah. Working out how to collaborate would be good. I see there's a comment in the chat. I'm not sure if you can see it, but this is from someone called Tivulawi. And he wants to publish his guidelines and wants to know what guideline, from the original research, which journal guidelines can I follow? Is there a reporting guideline for guidelines?
Oh, yes, the reporting guideline, there's the right statement and I can try to get the link very quickly. So it is for reporting guidelines. So let me just, so it's, I was involved in developing this a few years ago, and now there are a number of extensions that are being developed for this. One of them actually just came out today for adapting guidelines.
I'll post it in the chat.
Oh, yeah. So you should have the link, Tamara. Okay, so this is the link. So this is the link to the adapted one, and then there's the original right statement, and I'll also paste the link.
Ah, there you go.
So the second link is not for, yeah, okay.
I think one of the things is it's quite difficult to meet those reporting requirements if you're looking at this after your guideline is developed. It's really important because a lot of the things you can't do afterwards, like declarations of interests and things like that.
Mm-hmm. I agree.
Back to you.
Yeah, I don't see any other questions.
Maybe back to Amir. Thanks.
Thank you.
Thanks, Tamara, and thanks, Elie. Yeah, I don't see any other questions. Elie, are there any added, anything else you'd like to add in general, or any other bits of work that you might be working on, or things for us, for all of us to keep an eye out on?
Yeah, no, just just looking forward to you know, when we learn from what happened during the pandemic, where people engage in a more collaborative approach, you know, especially within and with low and middle income countries, because there's definitely a lot of resources and capabilities within, you know, the global South. So hopefully that would be an area of advance. Thank you.
Good. Thank you very much for those closing words. And just as a reminder, I'm adding the webinar evaluation link to the chat again. We always value your feedback, and it helps us in improving the way in which we conduct our webinars. Again, thank you very much, Dr. Elie Akl, for this excellent and informative presentation. And also thank you to all the participants, and thank you for all your questions and comments that have come through. Please look out for our email that will come through in the coming weeks on next webinars that will be advertised previously. So look out at our YouTube channel and our website, where we will be posting this webinar, which you can also share with your peers and colleagues. Thank you once again to everyone, and keep well and keep safe. Thank you again, Dr. Elie Akl.
Thank you.
Thank you. Keep well.